Hello, everyone, and welcome to PVACCS Physiology Crash Course in Circulation. My name is... Can we just make sure everyone's mic is off, please? Thanks. My name is Andy. I'm one of the event officers along with Matt. Now, before we launch into the structure of tonight's event, I'd just like to begin by acknowledging the traditional custodians of the land on which we meet today, and pay my respects to their elders past and present. I extend that respect to Aboriginal and Torres Strait Islander peoples here today. So now for today's structure, we'll just go on to the next slide, please, Rachel. So tonight's event will be about 60 minutes. In terms of the content, we'll be covering a bit about the cardiac cycle, physiology, the circulatory regulation principles of cardiovascular monitoring and types of shock. Towards the end, we'll have some time for some questions, about 10 to 15 minutes, and feel free to send those questions either in the chat or through the Slido, which we have the link and the QR code on the next page for you guys to have a look at. So that's the QR code, and we'll also post it again later towards the end for when we have the question time. Now, I'd like to, before we introduce our next speaker, I'd like to pass on to Tom, our sponsorship officer, to introduce our sponsor for tonight. Thank you, Tom.
Hello, everyone. Tonight we have a sponsor, Osmosis, which is basically a medical resource, notes resource available, and they have very kindly agreed to give a free 1 month trial to one of our viewers. So we're going to be selecting that lucky recipient from the chat. So make sure that you answer lots of questions and post in the chat as needed, and then towards the end, I'll be selecting someone and getting in contact via email with them. So get very engaged. And without further ado, I'll hand on to Matt to introduce our speaker.
Hey guys, pleasure to be here. It's even bigger of a pleasure to be introducing our speaker for tonight, Ade. He's a gentleman currently training in aesthetics in the Northwestern Consortium. Very much an outdoorsy person, light-hearted, loving his work. I hope he makes a good impression on you, and I hope tonight goes very well. So I'll hand over to Ade. Thank you very much.
Thanks there, Matt. So good evening, everyone. Thank you for coming at 6:30. I'll try to make this interactive and also worth you a while. Otherwise, why did you turn up at 6:30 to learn, other than to learn, right? Yes, as Matt said, I am an anaesthetic trainee at the Northwestern Training Scheme, and I have a special interest in medical education, airway, difficult airway stimulation as well, real life scenario, obstetric anesthesia, and I like everything that is relating to outdoor activities. Okay, I'll share my slides. I have around 50, but it should be okay. Share screen, Microsoft PowerPoint, that's one. Can everyone see? Wait, it says your screen sharing is paused. Resume. Let me try again. Okay, can everyone see? Great.
I can see that now. So
full screen.
I can see the presenter version.
The presenter version. Okay. Let me change that. Let me share. What about now?
Yep. That was good.
Happy? Great. And I can see everyone's faces. Okay, I think I've done intro and I've done the introduction to talk. I'm just reading my notes here. All right, next thing, this is really important. My teaching style is to get everyone to think, because we all are interested in the area of critical care. Some of us are particularly interested in anesthetic, and all of us should be put in a situation where there is a little bit of pressure, so we can learn a bit and also remember and get that sort of emotional reactions and forming new neurons and not new neurons, new connections in our synapses. And if you get it wrong, you know, who cares? Just keep going. And if you get right, you know, with the questioning, keep going as well. Sorry, I'll just put that in mute. And I just want to say this is a safe space. Don't be rude. Some people have more experience than others, and that's great. And some people don't have that much experience, but you guys are here, and that's already a good start. And yeah, give it a shot. So life's too boring if you don't try. And let's have some fun, hey? And the reason why you're here and I'm here is to get more of an understanding about circulation and cardiovascular physiology. Okay, so Matt sent me all the things that the team would like to cover, and it's actually a lot, but I'll try my best and give you a little taster of every bits of cardiovascular physiology and what I think are important. Starting off electrical conduction, followed by the cardiac cycle and terminus regulation of cardiac output. After that, the classic cardiac reflexes, and what I think is really important and comes up nearly every day. Beyond that is monitoring and equipment, and we'll also have some cases in there, putting in the basic cardiac physiology and clinical cases that you'll see in the wards on everyday life. Yeah, I think that should fit us for 1 hour. Okay, I'm gonna pick on people, and because I know Anthea and Matt are here and they're gonna have to leave, I'll pick on Anthea first. Anthea, can you describe the electrical conduction pathway of the heart?
Yes. So you have your sinoatrial node,
Yep.
which is electrical impulse. It goes through the atria, then through the AV node, then down the bundle of His, and then to the ventricles, which electrical activity causes contraction. Very simple overview, but essentially that.
Excellent. Well, the thing is, it's simple, but it's correct. And if you were asked that in higher level specialist examination, it's exactly what you write, and it's correct. Okay, and Matt, draw and annotate. I think everyone should grab a piece of paper and also a pen or pencil and whatever. And if you like to play along, it's great. Do you have a pen and paper there, Matt?
Yeah, sure. I think there actually might be a drawing function on.
Oh, is there?
It might be easier just to. I might just try and do it quickly.
Yeah. If you can draw, just draw away.
Sure. All right. I'll. All right. So this is a. I hope it's not backwards.
Bring it up a bit. Now label some of those little bumps that you get there.
So this is the P wave.
Yeah.
It's deflection caused from atrial depolarization. You got your PR segment here, describing the time for conduction to travel from the SA node through the atria, through the AV node, and then into the ventricular system where it actually depolarizes the ventricle. Most of this time is delayed at the AV node. At the ventricle, you got the Q wave, R wave, and then S wave. This will vary depending on what lead you're looking at and, you know, essentially what angle of the heart you're examining. This is the ST segment. So there's a delay between depolarization and repolarization, describing, and this period here is the refractory period. This is your T wave. So in terms of ischemic features with acute ischemia, this is where we tend to look here and here.
Perfect.
A bit of variation between where you are, but
correct. So so that's the basic lead to with a positive inflection on the R wave. If I click that, there you go, that shows up. So the height for everyone to know is 1 millivolt, and that should be 10 small squares. And do you know the speed of ECG of writing? Standard?
300 milliseconds. I know that a small square is 40 milliseconds.
Correct. So that's the second question. The speed of writing is 25 millimeter per second. And that's just a little question or a little fact. It's not really that important, but you should see, because I think some countries don't have the same ECG speed. Correct me if I'm wrong, but majority is the same. Okay, there you go. That's there at the bottom. 1 small square is 40 millisecond and 5 is 200 millisecond. And like, oh, la-di-da, why do we need to know this? Well, it's important because the duration of each path that is conducting in the heart is really important. If there is any delay or any shortening, we will like to know, and we'll also like to know why. And so I think we'll just focus one bit of it, because you can talk about it for a while. We can talk about the PI interval. We can talk about, as you have mentioned, ST segments, the RR interval, when you QT, and all of those are really important. But today I just mentioned about the PI interval. So thank you, Anthea and Matt. I'm moving on to Rachel now. I'm moving my way down. Do you know the definition of PI interval?
The distance between the P wave and the R in the QRS.
Perfect. Right. That's the answers in the question. How good is that? And is it at the start of the P or the end of the R? I mean, the start of the P or the end of the P?
Was it the start of the P?
Correct. Start of the P. And do you know the normal value? I'll give you a clue. I'll give you this little thing there.
I was going to say 120, I think.
120 is correct. It's between 120 and 200. So you've done well there. And can you name factors that increase, we'll start with factors that decrease PI interval and factors that increase PI interval.
If there was factors that would decrease, it'd be like if there was an accessory pathway, yes, that allows the action potential to get to the ventricles a bit quicker.
Mm-hmm. So that means the heart is beating faster, right?
Yeah.
Correct. Do you know any example that can?
With Parkinson's.
Perfect.
Syndrome.
Right. And physiologically, when you have tachycardia, how is that usually started? What drives that?
Sympathetic.
Perfect.
Increase.
Yeah. So that's the factors that decrease PI interval. Now flip it the other way. So now factors that create increase in PI interval. So you'll be more bradycardic. Yeah.
Yep.
Now I'll give you a little clue. I'll give you categories because it's easier to remember if you have categories. Majority, I give you 2 categories. One is medication, the other one is pathological. Anyone can chime in if you like as well.
Would you say beta blockers?
Nice one. And one for pathological.
Heart block.
Perfect. Okay. Wait. So there it is, 120, 200. Good job, Rachel. Is your heart beating? Are you slightly tachycardic now?
Probably yes.
Okay. You did perfect. You answered everything. And I think that's good knowledge that everyone should have when you start internship or residency. Start to get more of an understanding about the slight details of ECG. And then you can pick apart ECGs every time you get one. And then you can think about why is it looking like what they're looking at. Okay, so you mentioned Parkinson's-White, physiological tachycardia, increase in sympathetic nervous system, and the other way you have prolonged PI, you have heart block from 1st degree to 3rd degree, causes a bunch of crap, fibrosis, ischemia, infection, connective tissue disease, degeneration with age as well can cause a 1st degree. Medication beta blocker can increase your PI interval, digoxin, and calcium channel blockers such as verapamil or diltiazem. And so other sympathomimetics, I should have mentioned, should also increase your heart rate and decrease your PR interval. These are things that work in the heart. So adrenaline, to some extent, noradrenaline at high doses, atropine, dobutamine, isoprenaline, and those are the medications. Okay, so, and you're like, why is it important? Because when you become an intensivist or an anesthetist on a part 1 question, it's a past paper. So by doing and learning little bits every day, like what you're doing now, you eventually are studying for the part 1. How good is that? So it's bang for your buck. And I'm going to keep doing this because I think what I'm trying to show you guys will be relevant in day-to-day basis, as well as relevant passing exams, because, you know, I think this group is geared towards, you know, getting junior doctors towards that pathway. So I thought it would be a great idea for mentioning these sort of things. And you can see it was repeated 3 years. So it's a pretty good value to do that. So Rachel, you would have scored 5 out of 5 just doing that. So congratulations. All right. Okay, so now Anthony, it's Anthony around. Starts with A, so I'm gonna keep going down.
I think sorry, I think Anthony said before he was driving or something, so you won't be able to answer any questions.
Alice.
Yeah, I'm here.
Hey Alice. What year are you?
2nd year.
Med school or out of uni?
Med school.
Med school. Okay. Perfect. Do you want to have a go? I think it's perfect.
I can try.
That's it. That's it. Everyone can have a go, and I'll help you along the way. Okay.
Yeah.
So Alice, congratulations. You're an ED med student now. Scratch it off. You're on HMO, or you can be upgraded to HMO, whichever you prefer. So you've got an ambulance note and a patient is coming, Alice, and it's a 69-year-old male found collapsed with witness head shrunk. And he was unable to stand up, and eventually he was transferred to the emergency department. So I'll just help you a little bit. For usually any crisis scenario, what we like to do is what we call primary survey. Have you heard of that before?
No.
Yeah, so that's okay. And primary survey is basically going through systems and also safety. Have you heard about doctors A, B, C, D, E?
You mean airway, breathing, that kind of thing?
Perfect. Airway, breathing, circulation, and disability and other or examination. So that's what we like to do. And the other thing is what we call treat as you assess model. So that means if you find something that you could do, I think this is more relevant when you're working. If you find something that you could do, you do it immediately. Okay, so, oh, sorry, I went too fast. So you do your prior survey, D is danger, R is response, S for send for help, and then you do airway, breathing, circulation, disability, and E, right? So what we like to know is a bit more about the history, how he is now, and what we're going to do to investigate and how we're going to treat him. Does that make sense?
Yeah.
That makes sense, right? We like to know what's been happening, how he is now, what can we do to test, and what should we do to make him better or to prevent him getting worse. So that's what critical care doctors do, right? Okay. So you're an emergency, dangers everywhere. So how do you assess for response, Alice?
Check there is like do the GCS score.
Yeah. What's a quicker way?
Sorry?
What's another way to do it quicker?
Ask them questions, like if they're oriented.
Yeah, nice one, good. So if they're responding to voice, or if they're responding to pain, or if they're unresponsive. So that's what I like to call AVPU, AVPU, alert, verbal, pain, only to pain, or unresponsive, right? So that's easy to remember, and he's alert. Oh, well done. So you're a second year, you're probably going to ask for help. So I probably won't be comfortable doing this case, and that's fine. And and other more senior people come along, and that's sent for help, right? Doctors. All right, airway. What do you do to assess airway? I think you asked, you mentioned it before.
Check if there is any obstructions in the airway.
Yeah, perfect. So if they're speaking to you, they're forming sentences, if they're what we called, if they can do that sufficiently, that means it's patent. Yeah. So if there is an upper airway noise, or if there is vomit or anything that you could see, blood or mucus, then could be something in the airway that we have to suction out, or something that we need to do to manage. What about breathing? How do we assess someone's breathing system?
Like just, I think we can visually assess if they are like short of breath, or the use of accessory respiratory muscles.
Perfect. So that's one aspect. So respiratory effort, good one. What about things that you put in? What about this device that you put on their finger?
Oximetry.
So oximetry, yes, pulse oximetry. So they're SATs, and I'll just add you for the interest of time. So rest rate, and also listen to their lungs. Yeah, I'll give you an acronym. I'll just move along to be a bit quicker. It's called RATES. This will be taught in ALS2 for those HMOs that are doing ALS2 or ALS1. Rest rate is 12, and also on auscultation, reduce air entry bilaterally. T is for trachea, it's midline. Effort, as Alice has mentioned, no increase in effort breathing, and it's 94% rooming. So based on that, are you happy with his breathing? Is it bad, or is it good, or is it fine?
The breathing rate, I believe that's slow.
Slightly low, yeah.
The stat, or the oxygen saturation is low as well.
Oh, well, I think it's fine. 94% Roomie is fine. Less than 90 is usually I would call low, and depending on some people, if it's less than 92. So C, I'll move on. This is what we talk. This is our focus for today: circulation. These are the things that I usually do. So think about the easiest info you can get is ask the nurses for blood pressure and heart rate. What do you think of the blood pressure, high, low?
Low blood pressure, and then bradycardia.
Perfect. And you listen, and it's still heart sounds, no murmur, no pericardial rump. And these are the quick investigation that you could do. 12 lead ECG, you can ask for that. ABG chest X-ray, really easy to ask for. And other thing is POCUS stands for point of care ultrasound, is transthoracic echocardiogram. That's a bit more advanced. I'm struggling to do it in a bedside and, act on it if I see any abnormalities, because it can be pretty hard to do. And he has 2 large cannulas inside. And the stability, his GCS is 15, which is good. And blood sugar is 6, and he's on aspirin, atorvastatin, which reduces cholesterol, and empagliflozin, which is an SGLT2 inhibitor to treat diabetes, irbesartan, which is an ACE inhibitor. And you also do CT brain and C-spine because he fell on his head, and you want to see what are you worried about someone hit the head, Alice?
Like hematoma, epidural.
Intracranial pathologies, one-liner, right? Bleed, hemorrhage, name it. C-spine, same thing. You don't want to see a fracture and potentially leading to quadriplegia. Temp is 36.4, which is normal. Thank you, Alice. Well done. And I'll move on after Alice. Kathy, is Kathy around?
Yeah, hello.
Hey, Kathy. So you asked for an ECG, and you've asked for chest X-ray and ABG, but you get the ECG first. Let's talk about this ECG. Any comments?
It looks abnormal to me. So I'm a final year, but yeah, it looks abnormal.
I should have asked. Yeah. Do you have a system for breaking down ECGs?
Yep. So I think always confirm the patient first. It's a 12 lead ECG, and then like you look at the rate. So I think it's bradycardic. I think you like count the squares between the QRS and then 300 divided by that.
Yeah.
Which
is what?
Like 40 something.
Yeah.
And then you look at the rhythm. So whether there's like a P wave before every QRS, which I think I can see P waves.
Yeah. All of those statements I'm saying, yeah, is true.
And then you look at the axes. So I think it's not deviated. Normal axis. And then you look at the intervals. So I think the PR interval is long.
Yeah, increased, yeah. So Rachel mentioned the causes of increased PR interval. Do you remember them?
So heart block. And also drugs as well. Yeah.
Good one. So, and that's the PR interval is increased. Good one.
And then you look for, oh, sorry.
Yeah, go on. Sorry, I cut you off.
And then you look for like any ischemic changes or like ST elevation. And I can see ST elevation.
Massive.
2, 3 AVF.
What does that tell you?
It's an inferior infarct.
Perfect. Are you sure you're final year?
Yeah.
Good job. And so you have reciprocal changes from V2 to V6, yeah? Can you see that? So if it's up, so if in the pericardial leads, you have an ST depression. Correct. So what does that tell you? What could it be? So you had you said what you said initially was correct. Has a block, but what caused the block? You mentioned it. What's the most common cause of ST elevation?
Oh, an infarct.
Yeah, that's exactly right. So inferior segments, myocardial infarction leading to its 3rd degree block. You can see it's complete dissociation from the P and the QRS. Can you, if you look at the P is actually constant. So sometimes it can pick up 2 different rates. So one is atrial rate and the other one's ventricular rate. The RR rate is the ventricular rate, and you have an ST elevation and you have an inferior STEMI and a 3rd degree block. And also, next question, what do you mean there are 2 rates? Well, there are 2 rates because as who did I ask first? I think Anthea mentioned there are pacemaker cells in the sinoatrial node, and that travels through the AV node, the bundle of His. If there is any issues with sending signals from the AV node all the way down, the 2 different sites work separately. So the atrial rate is a lot faster than the ventricular rate. The base ventricular rate is 40. And this is what we call junctional escape rhythm. Nice one. Good job, Kathy. So what happened with our patient? So what are we going to do? Well, PCI, versus thrombolysis. You're in a Melbourne Centre, you're probably going to do PCI, and I'm not going to talk about the details about anticoagulation, aspirin, clopidogrel, ticagrelor. I'm not going to talk about that. I'm here to talk about circulation. So let's put it together. So essentially, the 3rd degree block lead to a very slow heart rate. And Kathy, do you know that what cardiac output is consisting of? Like the formula for cardiac output?
Is it stroke volume by heart rate?
Perfect. So his heart rate's low. So therefore he's hypotensive because he's not producing enough cardiac output. Yeah. So how do we treat it? Well, yes, we're going to treat the STEMI, and hopefully the heart rate picks up. Or if that doesn't work, we got to pace him. So we got to make his heart rate a bit faster. I don't want to give him some mimetics in this instance because you just train his heart to work harder. So that's could be not a good idea. Okay, moving on to cardiac cycle. Who's Jonathan Boyle? Are you there?
Yes, I'm here.
And which year are you in?
I'm in 6th year at Adelaide.
All right, perfect. So what's your understanding about cardiac cycle?
Well, it's the cardiac cycle. I guess it's the describing the events that occur within the heart.
Oh, I just realized the answer is there. Perfect. Yeah, exactly. So it's further divided to diastole and systole, right? Just remember, once you graduate, if you don't do medicine, most of the questions and basic physiology is really simple, and the answers in the question. So cardiac cycle, well, it's a cycle. That means is what goes around comes around, and what happens in the heart. There are two things that we sort of think about: diastole and systole. And it relates to changes in pressure, right? So when you have systole, you have increases in pressure, and diastole, you have decreases in pressure. And that can relate to the atrium and ventricle. Don't go away as yet, Jonathan. All right, next one. Let's think. Okay, so for me, describe the movement of blood from the right atrium to the pulmonary artery. I gave you a diagram to help you.
Yep. So the deoxygenated blood comes into the right atrium from the rest of the body. So either, as you can see, the SVC or the IVC, it gets pushed down to the right ventricle through the tricuspid valve, and then once systole occurs, and the blood's pushed through the pulmonary arteries to the heart. Sorry, not the heart, the lungs.
To the pulmonary circulation, yeah?
Yeah.
And you have, I just realized this lags a bit because I'm streaming. Okay, so this is a good way of learning what happens. So what happens when the deoxygenated blood, sorry, I should explain this graph. So on y-axis, Jonathan, you have right atrial pressure. Pressure is force over area, so you don't need to know that, but that pressure. On x-axis, you have time. I wrote that in a millisecond. You should always write your units, but I'm lazy. Oh, this is harder because it lags. Okay. What happens with the pressure in the right atrium when blood goes in?
Well, when you've got filling of the blood, the pressure increases.
Yeah, perfect. So slowly over time, pressure increases. That's what we call the V wave. And also following that, so before the end of what does the atrium do to move blood into the ventricle?
So it contracts.
Correct.
Push blood through the valve.
Yeah. So what we have an A wave, right? So this is pressure. That means pressure increases with contraction. And so after that, you have a closure of the tricuspid, and you said it moves through the tricuspid, and you have the closure of tricuspid, yeah?
Mm-hmm.
And then the right ventricle and the left ventricle contracts, so that we call that systole. What part of systole is that relating to?
I'm not exactly
Yeah, I think that's a read my mind question. It's called an isovolumetric contraction. Have you heard about that? It's okay if you don't. So that means the volume in the right ventricle doesn't change. So the volume is the same. So that means, remember this is right atrial, not the right ventricle. So when the right ventricle constrict, the tricuspid actually moves into the right atrium, and you have a small bulge, and this is what we call a C wave. And I'll just continue along from here. And what you said after that, then the blood moves from the right ventricle into the pulmonary artery. And what that does, it actually moves the tricuspid downwards, it sucks it downwards, and we have what we call an X descent. And after that, blood moves into the PA, It moves into the PA, and then once the pulmonary artery pressure is high, the right ventricle, it closes, and you also start to get filling. Okay. Oh, I should clean this out. How do I clean this? Oh, I need that. If I erase all ink. Here you go. What you said. RA more than RV, blood moves to the RV, and you get, I should have mentioned the Y descent. And after that, you get an atrial contraction. We've mentioned we have a ventricular contraction. We've also mentioned that, and also blood moves into the X descent. This is important because when you put a CVC into someone's internal jugular, or when you're looking at JVP waveform, that's what we're looking at. So next slide. Yeah, next slide. There you go. So essentially what we draw. So the P correlates to the A, and you have the QRS, and that leads to the ventricular contractions, and you have the C wave with that. It's easy to remember. Ventricular contraction is C, relates to C, and atrial contraction is A, because atrium starts with A and A. And then you sort of got to remember the rest. Okay. So that's relating to the atrium. Now let's talk about the left ventricle. I just go along and answer this myself. So I'll divide this to diastole and systole. So we have, actually, before you go, Jonathan, good job. And is diastole longer than systole, or systole longer and then diastole at baseline heart rate of 60?
Sorry, yes, diastole is longer.
Perfect. Okay. Oh my God, my pen function is crap. Because I'm streaming, I think that's okay. So I might skip the drawing. All right, so LV pressure last time, remember, was RA pressure, and this time we're going to talk about LV pressure over time. Who's down below? Is it Diptya? I see your camera's on. Hello. Diptya Paul, or did I say it wrong? That's all right. I moved on to Heather. Are you around, Heather?
Yep, I'm here.
Perfect. And what year are you in?
4th year.
Great. Out of 4?
Yeah.
Perfect. Okay. So first question first. How much pressure does the left ventricle have to generate before it can pump blood into the aorta?
Oh, I'm not sure.
What's your systolic pressure usually?
Oh, like 120 on, oh, like 120.
Yeah, yeah. What's your diastolic pressure?
80. So
Yeah,
like you have
perfect.
a pump 80 then to overcome it. Nice
one. So that's how you remember. So once the pressure in the left ventricle exceeds 80, I'm just going to draw it for you all. So here, blood moves into the aorta, yeah? And it closes just slightly above 120 and goes down. And then, oh, come on, you can do it. You can do it. Great, good job. So that's your diastole. So this is what you need. That's why diastolic pressure is sort of important to know as well. If you have a high diastolic pressure, that means the left ventricle has to work a lot harder to generate enough pressure to pump blood out. Make sense?
Yeah.
Great. I'm going to give you, this is what I call Wiggers diagram. This is going to come up a lot if you want to do intensive care medicine or anesthetic or ED as well. What you mentioned here, can you see the AT there?
Yeah.
Yep, so aortic valve opens, and when it reaches 120, so there's no difference in gradient. Remember, you need pressure gradient to move. When you don't have a pressure gradient to move, blood doesn't move. It tends to move the other way. So that's why you have an aortic valve and it closes. And this is what we call a dicrotic notch here, a slight infliction of pressure. And and then it goes down again, and then it goes up again. So that if you put an arterial line, that's what it looks like. If you put an arterial line in next to the aorta, that's what it looks like. We've mentioned the atrial pressure. Thank you, Heather. So that was a short one for you. We've mentioned the atrial pressure, and we also mentioned the ventricular pressure because that's essentially what we did. We'll skip ventricular volume, and if you look at the ECG, what Matt mentioned, the QRS coincides with ventricular contraction, and that's what we get. And the first and the second heart sound also relates to the closure of the aortic valve as well as the MV. Okay, moving on. I think we're getting more fun here. We have the determinants of cardiac output and cardiac output. So I think I have Jenna Shin.
Yep.
Hey Jenna, what year are you in?
Second year.
Med school?
Med school.
Great. Define cardiac output for me. So what you think it is?
Yeah, it's the amount of blood that's pumped out of the heart per minute.
Yeah, perfect. So the volume of amount of blood ejected from the left ventricle, specific, the heart, what you said, per unit time, and it's usually minute, yeah? So what's the unit? Like, if you're talking about mathematics or physics, what's the unit? So we have volume over time.
Yeah.
Yeah, so
a minute.
Yeah, perfect. And do you know, I think someone mentioned the formula for cardiac output. Do you remember what it is?
Yep, stroke volume times heart rate.
Yeah, perfect. And do you know the determinants of cardiac output?
So anything that changes the stroke volume or heart rate?
Correct. And can you go in specific a little bit more? You might not have heard these terms before, and that's okay.
Yeah. So with the stroke volume, I guess it depends on like end diastolic volume.
Yes.
And systolic
Nice one.
volume.
Yeah.
Yeah, and heart rate.
Yeah, so what you mentioned before, diastolic and systolic volume, the difference is what we call preload. So I don't think you have come across it, and that's okay. So completely correct. Normal value is volume over time. And I also want to mention that I know we got used to saying 5 liters a minute, but my cardiac output might be slightly different to someone else's cardiac output that's much shorter than me. A child cardiac output might be different, and a pregnant women's cardiac output is different. So I like to do it per kilo body weight. And normal adult, non-pregnant adult male or female is usually 70 kilo per minute. That's around 5 liters per minute. Determinants, these are the terms that I might need to introduce to everybody that hasn't heard it before. It's called preload, afterload, contractility, and heart rate. And these things determine stroke volume. Bam, there you go. So you see here, stroke volume right there, and heart rate right there. So it's actually quite easy if you just remember certain formulas, and you can remember the factors that come into them. Okay, so preload is what you mentioned before, it's end diastolic volume. And the easiest factor to manipulate preload is total venous blood volume. That means if you give blood, if you give crystalloid, if you give fluid, your preload goes up. If you change the venous vascular compliance, for example, if you give anything that acts on the veins, such as metaraminol, even adrenaline, increases your preload. This is sort of more of an advanced cardiology, physiology kind of thing, but hopefully this will come around when you get a bit more senior. Other things, diastolic filling time. If your heart rate's really fast, just say it's 160, really fast, you don't have time to fill the ventricle. So that means your preload gonna go down. Atrial pressure and AV valve function. So if you have mitral stenosis, so that means the mitral valve, not tricuspid, the mitral valve is narrowed, That means not enough blood's going to get through. That means less blood is going to be in the left ventricle. The other thing that I like to mention is the compliance of the wall. So the heart is composed of the myocardium and the pericardium. I'm going to write M and P. If both are thick and stiff, that means the compliance is low. That means it can't expand and the preload will go down. So what's more relevant is I just mentioned about the total venous blood volume and the Frank-Starling mechanism. Some people in this talk might have seen this graph or might have heard about who this person might be. So Starling law essentially saying that the force of the contraction of the ventricle is proportional of the initial resting length of the actin myosin. So just to recap, actin myosin is your building blocks of muscle. What's essentially what they're saying is that if you have a sufficient overlap between actin and myosin, and if you increase that amount of overlap, you have more cross-bridging forming, you would have an increase in stroke volume. And how do you do that? Well, you can add fluid, what we mentioned earlier before. You can increase the blood volume or change the venous tone, and you increase your stroke volume to here. Yeah, so that's your ventricular end diastolic volume. That's that. Afterload. So afterload is defined as resistance for ventricular ejection. That means the load that the heart must eject. Again, so there are two factors that I like to mention, the intrinsic factors and the extrinsic factors. Intrinsic factors basically relating to the heart. I won't go into too much details. I put it here. You guys can have my slides. It can be useful for revision later on down the line. Intrinsic factors related to the heart, and we'll talk about the radius of the heart chamber. So that means if there is more blood in the heart, it would have higher wall tension. That means it has a higher afterload. That means it has a high load that the heart needs to work against to pump the blood through. The other thing is ventricle thickness, which is T, which means if you increase your thickness, for example, cardiomyopathy left ventricular concentric hypertrophy, when the muscle thickens, that actually reduces the wall tension, because if you have the increase in thickness, that means the heart can work the heart remodels to reduce the afterload. Other thing is CPAP that is used in heart failure or when someone's intubated and on mechanical ventilation. Other things that you probably have come across is hypertension. So that's non-compliant vessels due to aging or peripheral vascular disease. And yes, so that's another factor. So extrinsic means outside the heart, intrinsic means to the heart. Contractility is easy. That means it's how hard can the heart contract. And factors that increase contractility, adrenaline is one. So those are drugs. So any sympathetic nervous system input, calcium, digoxin, glucagon, and also an increase in heart rate. Factors that decrease contractility, that's also easy. We have that within us, the parasympathetic nervous system, the vagal input, also hypercapnia, hypoxemia, ischemia, anesthetic drugs. It's very common. Propofol, sevoflurane, which is the inhalational agents, or any other ether drugs, and heart failure. So that's quite easy. So we've mentioned preload, afterload. Contractility determines the stroke volume, and you have the heart rate. We're going to do another case. So that's me. I was in Bali. You can see I'm holding a very important thing there. So this is your clue. I think I'm done with Heather. Oh, everyone shortened their name. Oh, come on. Well, if you haven't shortened it, good on you. Eva or Iva? Are you there? You know what? I'm just going to go back for the PVACCS team because they're gun and they're really smart. They're going to help me. So Rachel, you're an HMO, right? Second year, third year?
I'm intern.
Oh, you're an intern. Great. So you're an ED now. You met me. This is me. And I came back from Bali and I've been having diarrhea and vomiting. Oh, wait, no, I'm still in Bali, actually. See, because I'm still currently in hostel without air conditioning. That's also clear. These are my vitals. What do you think about my heart rate?
It's a bit fast.
Yeah, what about my blood pressure?
My blood pressure's a little bit low.
Yeah, and that's me happy, obviously. GCS 14, so I'm responsive to you, but my eyes are closed. What are you going to do? I need help. What's the assessment of critical care patient?
ABCD.
Perfect. So no danger, I'm responsive to pain, no voice, sorry, and I don't think you need help with me. Airways patent, breathing is breathing's fine. And then that's your circulation. What do you think overall is going on? What do you think my blood pressure is so low?
Because you've had a lot of diarrhea and vomiting, so
yeah, what does that mean?
Fluids.
Yeah, fluid loss. Perfect. So my preload would go down. Yeah.
Yep.
So therefore my stroke volume will go down. Yep. And one thing I haven't mentioned is what's a quick way of determining blood pressure? A formula.
I think is it 2/3 of the diastolic plus 1/3 of systolic?
Yes, that's true. But the other way is involving cardiac output.
Cardiac and resistance.
Yes. See, I swear to God, I'll write a lot better than I draw. Okay, so cardiac output times total peripheral resistance. If my cardiac output is low and my blood pressure can also go down. And the reason why I'm low is I'm low in preload. So what's my treatment?
IV fluids.
Nice one. What kind of IV fluids?
Normal saline. I'd go.
Yeah, nice one. Normal saline's good. How much? I'm fit, by the way. Look at me. I'm fit, young male, no heart failure.
Go a liter.
Yeah, only 6 days.
2 liters?
Yeah, a liter is right. So a liter and you check, and then you give another liter and you check, right? Yeah. What you said was right. So normal saline and CSL is what we know as crystalloids. They're effective for fluid resuscitation. Someone has hemorrhage, there's someone that hasn't had any oral intake or can't tolerate oral intake, IV crystalloids, whatever volume. If they're fit and well, no heart issues, let's presume kidney is happy, then that's a great idea. Okay, this is more an infectious disease question or general ED question. What other investigation would you do? You're an intern now.
Just basic bloods.
Yep.
FB, UEC, CRP.
Okay, what do you look for in UEC?
Looking for electrolyte derangements.
Yep.
Making sure the kidney's okay.
Yep, great. Kidney's okay. And why is he still pooing and vomiting for 6 days? What are we thinking about? What's going on in his tummy? Stool sample, multiplex PCR, C. diff, yada, yada, yada. And the thing that prevents them getting worse is fluids and plus and minus antibiotics. Okay, so check for organ injury is essentially what you did. So you would do a full set of bloods, FB, UEC, check for your creatinine and EGFR, and you also look for any hepatic injury. And you would think my brain would be fine because I'm still responding to you. So the diagnosis is hypovolemia, secondary to excess fluid loss from diarrhea, and also it was hot in Bali, so sweating, a lot of fluid loss. So you got to consider that. If you're in tropics, your fluid loss from sweating is a lot higher. Okay, so what do? According to Frank Starling, you increase the preload with a liter of what you gave, and you're going to improve my stroke volume, and you're going to return my blood pressure, and my heart rate eventually will come down. Happy?
Yep.
Good one, Rach. Okay, so this is another dude. I won't ask this one because this can be a bit more complex, but we'll just do it anyway. 70-year-old, 40-pack-year history of smoking, hypertension, really bad diabetes, and also so much cholesterol. This is probably the gentleman here in this photo as an example. He came into emergency with worsening history of lower limb claudication, so he probably got peripheral vascular disease. I'm not going to bother writing, and it's awaiting lower limb angiogram. He's really bad with his understanding of his current health. He's not complying with medication. His blood pressure is 190 over 90, and there's a left axis deviation, displaced apex speed. Can anyone tell me from that examination what is going on with his heart? It's okay if you get it wrong. Well, wait, I'll tell you this, LV hypertrophy. So it's concentric hypertrophy. What I mentioned before, the wall gets thicker, so the thickness of the heart gets bigger because it needs to pump against a very stiff arterioles and arteries. So this is an example of a high afterload leading to an increase in thickness of the heart. So this is a physiological adaptation, and what you see in ECG is left axis deviation, also in examination as a displaced apex speed. Okay, so I wrote it there. So increase the wall thickness, the wall tension goes down, because it's some difference in pressure over the wall thickness. If that goes up, the wall tension goes down. And the trade-off means the heart needs to use more oxygen to pump. And the extrinsic factors that is going on with this gentleman is treating his hypertension, treat him to stop smoking, fix his diabetes, fix his lipidemia, and all of those will improve his afterload. So his heart will be in a better place. I don't think the hypertrophy can reverse, but it can reduce the overall oxygen requirement. Sorry if it's a bit detailed, but I think this is an essential cardiovascular physiology. Okay, so, oh wow, why is it so important? It came up so many times in the part 1, part 2 questions. So if you guys are heading that way, or if you're interested, these are the cardiovascular physiology questions that will be asked and also can be related to your clinical day-to-day basis on why things are happening. Okay, now, so we're moving on to the third part of the talk, which is reflexes. Kathy, you're a final year, aren't you?
Yeah.
Yeah, sorry to bug on you again. You've done your obstetric term, I assume? Yeah,
last year.
Yeah, great. So you find a 29-year-old female, she's postpartum, G3P2, and just pretend this is your internship placement. You got a met call for drowsiness. No one in the team could come except for you. I know, it's scary. What are you going to do?
So start with the primary assessment doctors A, B, C, D, E.
Perfect. Yeah. And so I'm just going to tell you a bit more of progress. Okay, so you look at the notes and everything. So that's the reason why I keep asking is because if you don't have a system of what's going on in a critical care scenario, just use that. You'll find something that's wrong that you can do. Okay, so she's day 0 post-Caesar. lost about 2.5 liters over 24 hours. 1 liter loss in C-section, further 1.5 liters in the ward. Her heart rate's 130, BP's low. Oh, looks like me after Bali, to be honest, right? And GCS 13 to 14, so that's why she's drowsy. What are your priorities? So access is really important. If you've realized someone has lost that much blood, it's 2.5 liters. It's quite safe to give fluids that is approximately 2.5 liters, because blood loss is liquid, yeah? When you replace crystalloids, normal saline CSL, with the same volume, no blood, at least you would still have volume. So that's an important point. It doesn't have red blood cells, it doesn't have coagulation factors, but yes, those things are important, but the things that is really important for the heart is what we, as I have mentioned before, is preload. So you can replace that quickly. IV crystalloids, I mentioned, packed red blood cells and other coagulation factors if required. So fresh frozen plasma or cryoprecipitate or fibrinogen. I think this is a bit more detail, but that's okay. What tests are you going to do? You can check for hemoglobin really quickly by doing a hemostat. They might have it. Otherwise, FBE, ABG, VBG is really quick to get hemoglobin. You don't need to know what rotum is. It's basically a point of care testing of coagulation and coags to see if the patient is coagulating or not. Other things to consider when you bring her back to theatre is outline to monitor her blood pressure. What we're going to do, management of postpartum hemorrhage. Okay, the talk is about circulation, so we're going to focus on circulation. What is the goal for the cardiovascular system, Jenna, Shin? If you lose blood, what does the heart wants to do?
It wants to speed up.
Yeah, it wants to speed up. Why?
Because you want to maintain the cardiac output.
Yes, and we talked about cardiac output. Perfect, good job. So cardiac output, as I've mentioned, is blood pressure, yeah? So it relates to blood pressure. So what the heart is designed to do is to prevent other organs dying. That's really important. So it tries its best to compensate. It detects there's something wrong with the body, but the heart will work 3, 4, 5 times as hard to prevent all the other organs from dying, because when all the other organs die, that's called shock, or if they have infarction elsewhere, the heart's got to work a lot harder and the body will die. So that's the main system, the main function of the cardiovascular system during hemorrhage. And you probably have done this in your first year medical school. This is the cardiovascular high pressure baroreceptor reflex. And the way you divide it is sensor, integrator, and effector model. Sensor, this is your heart, and that's the arch of the aorta, it's here. And there's also one in the carotid. That's what we call baroreceptors, which means it's a pressure receptors. And your integrator, which is your smart computer that everyone has in their brain, detects there's a decrease in blood pressure and essentially saying we need to do something to prevent all the other organs from dying. So what we're going to do is activate the sympathetic nervous system, and the downstream effect is the heart, we have mentioned. Other things is the blood vessels, other things the kidneys, and adrenal medulla, which is the party hat that sits on kidneys, and other organs that doesn't necessarily need blood. Do you know what those are? Well, I'll tell you anyway. So like the gut, for example, and resting muscles that doesn't really need blood, and skin for another example. So divert blood away. That way, we can increase our cardiac output. So now I'm going to talk about why you have vasoconstriction. So you have vessels constricting to maintain pressure. So the organs have enough pressure to get blood. The kidneys essentially help you because it's going to prevent further blood and fluid loss, not blood loss, fluid loss, decreased fluid loss. And wow, I'm going to stop. And that's how it does that. It's by the renin-angioaldosterone system. It doesn't work immediately. It takes a couple of hours to days to work. So it's not the fastest response, but this is the fastest response. Okay, so that's why your heart will work faster. You get tachycardic and you can have cooled peripheries. I won't mention the low pressure baroreceptor reflex for the interest of time, but it's there. And this is essentially what we talked about: decreased cardiac output, decreased mean arterial blood pressure. You get detection in the mechanoreceptors, and it goes into the brain. It's in the medulla, and essentially you get venous constriction to increase your preload. And so I'm going to write P, and you have increased contractility, increase in heart rate, and you have also arteriolar constriction to maintain blood pressure. As we have mentioned, blood pressure is cardiac output times cardiac output times total peripheral resistance. Perfect. And cardiac output is stroke volume times heart rate. And if you look in this diagram, heart rate's here, and we talked about determinants of cardiac output, which is our contractility, our preload, and also our afterload. And if you increase your stroke volume, you have an increase in cardiac output. See, it all comes together. Hopefully that makes sense. And after that, you have increased cardiac output, you get an increase in blood pressure. What are we doing that? What is the body doing that for? Is to prevent the organs from dying. Okay. I think we're reaching to the final bit. This is a bit more complex, but I'll mention it anyway. I won't bother with the equation, but it's there. It helps you to think it through. So shock is essentially organs dying, right? So generalized inadequate blood flow through the body to an extent that body tissues are damaged. The easiest predictor is an increase in lactate because of too little oxygen delivered, and that's usually can be due to a decrease in cardiac output or a decrease in oxygen content in the artery. I'm just going to quickly go over 4 things: hypovolemic, obstructive, cardiogenic, and distributive. Hypovolemic is what we mentioned with the lady that we had a lot of blood loss from the hemorrhage, from postpartum hemorrhage. What happened to me with lots of loss of fluids and also loss of electrolytes. People with pancreatitis and severe liver disease, they just intravascularly deplete. Obstructive, pericardial disease, so the heart can't pump as hard. Pulmonary embolism and pneumothorax, they can't fully give enough oxygen into the arteries because the lungs aren't working well. Cardiogenic, decrease in contractility, valvular dysfunction, again, issues with afterload perhaps. Dysarrhythmia, the heart's not contracting properly, so it can't generate that pressure we talked about that it's required to pump against the aorta. Distributive is basically dilation, vasodilation. That means increase in diameter of the vessel. Sepsis is a common one, anaphylaxis, vasodilator drugs, anesthetic drugs. Neurogenic, if you put a spinal anesthetic into someone's back, you can potentially lead to neurogenic. And also local anesthetic toxicity can also lead to neurogenic shock. So those are the 4 categories, and these are the 4 subcategories, okay? So shock. So this is the most important equation to understand about shock. So cardiac output times DO2 means delivery of oxygen equals cardiac output times oxygen concentration in the arteries. If both are low, you get decrease in O2, which makes sense. So what do? Treat the cardiac output, or treat the oxygen, or treat the cause, what we mentioned here. Okay, so I think this isn't a very last slide. This is a bit more complex, but let's do it together. If you've done your surgical term, or if you've done, if you're currently in the surgery term as a resident or intern, this can happen. 50-year-old, 54-year-old male currently in the ward with worsening abdominal pain, currently day 3 post-hemicolectomy for a perf diverticulitis. So it's day 3 post-operation. The patient has ongoing vomiting and NG tube on free drainage, and also decreased oral intake. That should give you a ring. So decrease preload, because there's not enough blood in the heart. In the circulation. Oh my God, I'll stop. Interns, residents have trouble putting cannula in, so there isn't any fluids going in. Other thing is, patients have been having worsening abdominal pain with tachycardia, and has had a MET call overnight for pain crisis, and also hypertension tachycardia. I think this is a pattern that we see. So imagine if I was the person seeing this, what am I thinking and what I should do for this patient? So I would always start with doctor's ABCDs, like, who's this, what am I dealing with? The things that could kill him, I would like to know now. So airway, breathing, circulation, disability, and examination. Okay, so rest rate 28, he's in pain, decreased air entry, he's breathing really quickly, but his SATs is fine. Okay, so that's good. His SAT is 95% room air. That means if we look at so here, I would think less that this will be an issue, the oxygen content in the artery, because his breathing is fine. But his pulse is weak. His heart rate is 140. His blood pressure is 80. He's got dual heart sound, no access. What are you going to do? Put an access in. How can you get it quickly? Well, if you can't do it yourself, just call someone. Hey, it's a MET call. People have tried, ultrasonic access is needed. He's really unstable. People, anaesthetist reg, anesthetic reg, ICU reg will be happy to come down. GCS 13, a bit drowsy. Drug chart is whatever. Just imagine fit and healthy, except for he's on antibiotics. He looks tired, and his abdomen is tight and is very tender, and he's got guarding. His lactate is 4 when you've done an ABGs and metabolic acidosis. Jenna, can you tell me what this is, the ECG?
Is it atrial fibrillation?
Perfect. So the reason why I would like to mention AF is, with AF, your atrium is not contracting properly. That means there's not enough blood going into your ventricle. That means it's not going to pump enough blood out of the ventricle. So if you can treat that, that's good. But the meds that we give to treat atrial fibrillation would also decrease blood pressure. But now he hasn't had IV fluids, so I think that's our priority. So I'm just going to end show here. No, it's deleted. Oh, no. Can you still see or no? Can everyone still see?
Is
it my email?
PowerPoint. Yeah, it's your email.
Oh, I think. Oh, look at that, Strava. Okay. Can you see this? Is it too small?
No, we can see that. Yeah.
Okay, great. So issues I've mentioned earlier: decreased oral intake, intra-abdominal sepsis, AF pain, and also because it's going back to anesthetic, propofol, sevoflurane, yada yada yada. So what would it have? What would the effect be on our cardiac output? So decreased oral intake fluid, decreased preload. We've mentioned that before. You're going to have decreased cardiac output. Intra-abdominal sepsis. We think there might be an infection going on. you're going to have a decrease afterload, decreased total peripheral resistance. Remember when we mentioned decreased total peripheral resistance, we're going to have a decrease in blood pressure. That means it is struggling to deliver blood to organs. Atrial fibrillation, the heart, well, particularly the atrium is not contracting at the right time, so it can't give us that kick of blood that's needed in the ventricle. Pain, it could be the driver of the AF, or it could be the decrease in oral intake that's the driver of the AF. Overall, there you go, decreased cardiac output, decreased blood pressure, decreased cardiac output, decreased cardiac output, and blood pressure. So anesthetic drugs could worsen them. What are we going to do? IV access, priority in the ward, give crystalloids, lots of it, 2 liters. And then how do we actually treat it? Well, he needs a washout, right? He needs to go to theatre, clean his source of sepsis. He needs antibiotics. What are we going to do about his AF? But hopefully, if with the fluids is good and you see an improvement in blood pressure, we can rate manage. Pain, well, it's quite obvious. We think it's another issue, post-op issue. So we're going to have another look and give him also some pain medication. What are we going to do? Because we're going to give some anesthetic, and that's going to decrease his cardiac output and blood pressure further. Well, we're going to need some vasopressors. Those are metoprolol and ephedrine. I won't go into how they work, but those are the common agents that we use, okay? Okay, I think I'm going to the last bit. I just realized this going to 8. I'm just going to mention 2 things that's really important. So there you go. It's a past paper described the immediate cardiovascular response to sudden 30% loss of blood volume. We just did that in our obstetric patient, and we talked about the baroreceptor reflex, which is this one. Just literally just want you to talk about this, and you get a good mark on that question there. Sorry. And then the other thing is other physiological responses that cause oliguria in response to hypovolemic shock, but won't go into that. Okay, we'll talk about 2 equipments. I told you there are a lot of things today, so I'm trying to fit everything in. Equipment and how stuff works. So 2 things that you might see or come across into your clinical journeys. Nearly finished. So we have the non-invasive blood pressure and also arterial blood pressure. Okay, the non-invasive. How does it work? Well, if you're a med student and you just see, oh, it just works, it just spits out numbers, and that's great. But if you want to know more, this is how it works. So you have a cuff. You have 2 lumen in the cuff. One of them gives air into the cuff, and the other essentially detects when you listen to your using your stethoscope for the sound, it's essentially detecting vibration. That's what we call oscillometric analysis. So step by decrease in blood pressure, and it detects changes in your vibration, and that gives you your systolic and diastolic blood pressure. So essentially the computer has a smart detection of changes in vibration with a stepwise decrease in blood pressure, and that relates to the patient's blood pressure. Another thing is outline, not that outline, this outline. Outline that you put in your radial artery, so that's the little catheter there, and it's connected to transducer. Transducer is essentially changing the pressure that we detect in the artery into a signal that you see in a monitor. That's what a transducer is. It's connected to a bag that is flush with saline. Okay, so why outline? Well, outline is really good because it detects beat to beat changes in blood pressure. And the way it works is that in your transducer has this thing called a diaphragm. And what a diaphragm does is with blood pumping against the diaphragm, it changes the resistance that's connecting to the diaphragm, and it converts that signal, the change in electrical signal, into blood pressure. That's long story short. So it's 8 o'clock, and I just realized I've talked a lot. And there are other 2 things that another thing that I could mention is how echo works, which is an ultrasound. but I won't get into that because it's 8 o'clock. And yeah, hopefully it's useful. I know it's really dense because I'm trying to cover all the things that Matt told me to cover. But yeah, I think everyone that attended did well for attending, and thank you for everyone that participated. Any questions?
Yeah, I was gonna ask that. Any last minute questions, anyone? Feel free to post in chat or unmute. I did notice there was no questions in the Slido, so I think that just means you must have covered all the concepts really well.
Or it's really dull and it's too much, but I'm sorry, but this is really important if you like cardiology and cardiovascular physiology or crit care. This is really important. Yeah.
Were you happy to mention before about sharing the slides? Because someone's just asking, will these slides be shared at all?
Oh yeah, of course I'll do that. Happy to. Okay. I might just remove my photo out of it.
Yeah,
but happy to.
In that case, yeah, we might post
them
like on the Matt page or afterwards.
Yeah.
All right. So yeah, if there's no questions, then we'll wrap it up there. Thanks, Ade, for coming to speak today. It was great that it was really useful that you related it back to the primary exam questions, because that's what the objectives that we were hoping to meet. And yeah, it was just a good kind of like revision of basic physiological concepts and then applying that to cases. That's useful. We found that a useful way to learn and remember things. So thank you.
You're welcome. And I'm sorry it's 8 o'clock. Have a good evening, everybody. If you haven't had dinner, enjoy dinner. And yeah, hopefully we'll come across some cross paths somewhere. And yeah, thank you.
Yeah, thanks everyone. We'll with the Osmosis Prime winner, we'll announce that later on the event page. And yeah, thanks for coming, and look out for our next event on the 7th of March on basic pharmacology.
Thank you. Bye.
Bye. Thanks, Ade. Thanks everyone.